All right, welcome back. This is part two of digestive disorders. So, in this lecture, we're going to talk a little bit about the gallbladder and gallstones. We'll talk about jaundice, infectious hepatitis, and some of the manifestations of hepatitis. We'll talk about liver cirrhosis and some of the signs and symptoms associated with liver cirrhosis. We'll talk about pancreatitis, and we'll talk a bit about celiac disease, and we'll compare Crohn's disease to ulcerative colitis. We'll talk about irritable bowel syndrome, appendicitis. We'll compare diverticulosis to diverticulitis, and then we'll finish up with colorectal cancer. So let's start off with gallbladder disorders and jaundice. Let's do a little bit of a quick review. I think seeing some of these pictures and getting a little bit of an anatomy review will really help you out with understanding some of the concepts in terms of the manifestation and why some of the symptoms. So here we have the liver, and you can see the shadow. You can see a little bit of the gallbladder and then the shadow behind it. So you could see the right hepatic duct and a little bit of the left hepatic duct, and then both right and left hepatic duct form the common hepatic duct. Here's the gallbladder, here's the cystic duct, and eventually the cystic duct and the common hepatic make the common bile duct, which comes in here and enters into the duodenum. The pancreas also has some duct work that leads into the duodenum. We know the duodenum is the first part of the small intestine, so when the stomach empties its contents into the duodenum, there's a lot of digestion that starts right here. That's because you've got liver enzymes, you got bile coming from the liver. The liver makes bile, stores some of it in the gallbladder. The gallbladder contracts in response to cholecystokinin that's released from the duodenum, and then it enters here and emulsifies and breaks down the fat. And then remember, the pancreas is a mixed endocrine. It's a mixed organ, both endocrine and exocrine function, with the majority of the pancreas being exocrine. So it produces enzymes that break down proteins, fats, and carbohydrates. Plus, the chyme that enters the duodenum is very acidic, so the pancreas produces sodium bicarbonate to try and buffer out some of that acidity so you don't get a duodenal ulcer. Okay. Here's just we'll remove the gallbladder. So now, we'll remove the liver so we can see the gallbladder with both right and left hepatic ducts. There's the common hepatic duct. Here's the gallbladder with the cystic duct, and then here's the common bile duct. And you can see there's an entrance here into the duodenum as there is entrance to the pancreas. So the pancreas is releasing its digestive enzymes, and so is the gallbladder. Now, when the gallbladder contracts, it's going to release whatever's in here into the duodenum. And then what's in the duodenum is going through the intestines, and whatever's in the intestines has basically two fates. It can either be reabsorbed by circulation, or it could be eliminated through bowel movements. So that means that whatever is released from the gallbladder, which is cholesterol, bile, phospholipids, water, all of those things can either be eliminated or be reabsorbed. Okay. So liver, what are some of the important functions of the liver? Well, it produces bile. It's involved with detoxification. There is the interconversion of nutrients. It's like a conversion factory. It could take one thing and convert it into something else. It stores a lot of vitamins, A, D, K, B6, B12. It stores some minerals like iron. It's involved in the destruction of red blood cells. We'll see that shortly. It's involved in producing cholesterol and lipoproteins. It's involved with immunity, and it's involved with coagulation. So it's once you know what some of their functions are, when the liver malfunctions, then that means there's going to be a problem with immunity. There's going to be a problem with coagulation. There's going to be a problem with the destruction or hemolysis of red blood cells. There's going to be a problem with vitamin K, with vitamin D, with iron, with detoxification and bile. When we look at the liver here, now it looks like there's a lot that's going on, but I want to show you something that's very important. So we know that the liver is involved with detoxification. So we have toxins that come in, and they could be endotoxins or exotoxins. Toxins coming in from the body or from the environment. And the goal is that as these toxins come in, it goes through phase 1 of liver detox, then it goes into phase 2, and then eventually phase 3, which is outside of the liver. Phase 1, the cytochrome P450 enzyme system, is involved in trying to take these toxins that come in as fat soluble, and the goal is to make them less lipid soluble and eventually more water soluble for excretion through urine or bowel. Okay? And in this phase, you see there's a lot of different biochemical reactions of oxidation, reduction, hydrolysis, and in phase 2, in the conjugation pathway, sulfation, acetylation, glutathione conjunction, methylation, we've heard that word before. Then there's many nutrients needed and vitamins to support each phase. So for healthy phase 1, you need riboflavin and niacin and pyridoxine, folic acid, B12, glutathione. You need your branched chain amino acids, flavonoids, phospholipids. Now, you heard me say in an earlier lecture, if someone breathes in a heavy scent or a cologne or perfume and it gives them a headache immediately, that their liver needs to be detoxed or they don't have the right nutrient support. So things can come in too quickly and then they overspill into the bloodstream and can give you a headache rather than filtering out the toxins and then eliminating them through urine or stool. Okay? So the reason why I say don't do a detox without doctor supervision is when the toxins come in and the liver is breaking them down, there are free radicals that are created. In between phase 1 and phase 2, there's a lot of reactive oxygen species that are created, and these are damaging to your DNA. So it's very important to have antioxidant protective nutrients in your diet while you're going through a liver detox. Otherwise, if you're deficient in phase 1 nutrients or deficient in some of these amino acids for phase 2 or in these antioxidants, detoxification can do a lot of harm. In fact, the detoxification process of trying to remove those toxins is more dangerous than the initial consumption of them. Okay? So some of those toxins that come in, the endotoxins, could be just, natural byproducts or end products of natural metabolism. And the exotoxins that are coming in could be from medications, over-the-counter medications, agricultural chemicals, food colorings or additives or dyes, household chemicals, pollutants, contaminants, microbes. All of those toxins come in. The liver's got a heavy load. It's got a lot to do. If phase 1, let's assume phase 1, you have all these vitamins that are perfect, you have all the appropriate antioxidants to counteract the reactive oxygen species that are made as we go from phase 1 into phase 2. Let's say phase 2, you have all the proper nutrients. Now we go from these toxins coming in, they're made completely, they're conjugated. That term conjugated means they're made water soluble, and once water soluble, we can get rid of them through the blood, kidneys, and eventually urine, or from the bile into the feces and stool. Okay? And If the urinary pH is somewhere around 7.2 to 7.3, then you can remove most debris in one pass through the liver into the urine and bowel and eliminate. If the urinary pH is 5.5, 5.8, 6.0, it's not enough to clear the toxins in one pass, so it gets reabsorbed and goes through the liver a second time, and a third time, and a fourth time, which is why we really need to make sure we have enough vitamin C, vitamin E, selenium, copper, zinc, manganese, CoQ10, thiols that are found in garlic, onions, cruciferous vegetables, bioflavonoids, to make sure that it can quench these damaging free radicals and the superoxides. Okay, so liver, very, very important organ, has a lot to do with detox. Now you have a little bit of an understanding. And I just want to be clear, it's not that like phase one happens in this lobe here of the liver and then phase two only happens in this lobe. That's not the case. Okay, it happens throughout the all the lobes and cells of the liver. Okay, so now let's move on. Cholelithiasis is all these terms look alike, right? Cholelithiasis, cholecystitis, cholangitis. So it's important to know the subtle differences. So cholelithiasis, chole means sac or gallbladder, and lith means stone. So gallstones, that's the formation of gallstones. And these gallstones are solid material. And I'm going to show you a picture of them. They really look like stones or rocks. They're sometimes called calculi. They could be formed in the bile, in the gallbladder, and they can be made of calcium and cholesterol and toxins. Cholecystitis, this is when you have inflammation of the gallbladder and the ductwork within, and the cystic duct. Cholangitis, this is inflammation that is related to an infection of the bile ducts. Cholelithiasis is an obstruction of the biliary tract by gallstones. Okay. Gallstones can vary in size and shape. They form in the bile ducts, the gallbladder, or the cystic duct. And they can be made up of cholesterol. They can be made up of bile pigments. They can be mixed contents with different calcium salts. The small stones may be silent, and they can be excreted in bile, and you don't even know about it. The larger ones are a different story. These larger ones obstruct the flow of bile in the cystic or the common bile ducts. Just go back a few frames if you need to just review that basic anatomy. And it causes severe pain. And that could be referred to the subscapular area, typically the right posterior scapula. When I was in school so many years ago, when we learned about cholelithiasis, it may not have been politically correct at the time. Everyone, you guys are in school at a really good time. When I went, it was really rough. Instructors were very difficult, not quite very respectful to students, somewhat demeaning. It was just a really, really hard time being a student. They just kept beating us down and beating. They didn't care. There was no empathy. And it was tough, man. I mean, I remember I was taking I think at my busiest time, it was probably 28 credits in a 10-week period. And that could be anywhere from, 8 to 9 classes at any given time. So it was very stressful. But anyway, during that time, the teachers were pretty straight and direct. They weren't worried about hurting anyone's feelings. And when it came to this topic on gallstones, they would just say, yeah, the risk factors for gallstones, females that are fat, 40, and fertile. Just like that. Fat, 40, fertile, fair-skinned, all the Fs. But now, we're a little bit more tactful, a little bit more sensitive to everyone's emotions and feelings. So we may not say fat, we may use the word obese. And even saying the word obese or obesity could be somewhat offensive. So a lot of the time, it really comes down to the tone and how it's said and why it's said, right? I mean, if you go up to someone and go, "Man, you are obese," that could be quite insulting and very offensive. Um, but if I'm with a patient and I'm doing their BIA and we're talking about body mass index and we grade them and I will show them a chart, instead of saying it, they can look for themselves and I could say, okay, your number is this. Can you show me where that fits on the chart? And then they point to it. And, it may not say morbid obesity, it may say obesity. So to me, that's a very tactful approach where I'm showing them the information. Yes, maybe their feelings may be hurt, but look, sometimes feelings are hurt, and that's enough to drive and motivate change as long as it's not done in a hurtful way, but it's done in a constructive and helpful way. Okay. So, anyway, gallstones are more likely to happen in women with higher cholesterol, obesity, and multiparity means fertile, very fertile, and many pregnancies. That's what multiparity means. The use of oral contraceptive or estrogen supplements increase the risk. Alcoholic cirrhosis, hemolytic anemia, and any biliary tract infection. But the biggies here that we see it, women, typically 40 or older, fair skin as well, obesity, multiparity, fertile, many pregnancies, and also the oral contraceptive. Clinically, often asymptomatic, unless there's a large obstruction in one of the ducts, right, by a large calculi. Let's see what else. The pain, when it comes on, it's a sudden severe wave of radiation. Powerful. There's nausea, there's vomiting, cramping, pain continues, and then jaundice may develop. That's that yellowing of the skin or yellowing of the eyes. The bile backs up into the liver and the blood. And when bile backs up, sometimes if you can't get rid of it, it gets stuck in, let's say, the tissues, it can lead to pruritus and itching. If there is the risk of a ruptured gallbladder, right, if the obstruction persists and the pressure builds up. The pain is decreased if the stone moves, if it's small enough and moves into the duodenum. So here is the liver. Now here looks like a stone that's exiting the left hepatic duct. This is the right side. This is the left. And it's moving down. Here is from the gallbladder. Here are stones being pushed down. This is the common hepatic duct. This is the cystic duct. And now you have the common bile duct. These are the gallstones. And now this large one here can get lodged right in there. Now this can be a problem because anything that's coming down this way is going to back up. Anything coming from the liver is going to get backed up. And if it backs up here into the liver and you start to get necrosis and liver cells die and you get fibrosis, that's a problem. If it backs up into the gallbladder, you get that is a problem. If you have a lodged stone here, as the pancreas is releasing its digestive enzymes, it backs up and it can lead to an acute pancreatitis where the pancreas starts to digest itself. It auto-digests itself because of its own digestive enzymes, okay? Because remember, it's exocrine as well, not just endocrine. Again, just another great picture, the liver, here's the gallbladder. You can see the ductwork very nicely coming in. Here's the pancreas coming in. When the duodenum has fat in it, it will secrete from the epithelial cells cholecystokinin that goes into the bloodstream. Eventually, it triggers the gallbladder to release all of its contents into the duodenum to break down the fat. What's in the bile is water and phospholipids. Those are the emulsifiers. And then we have bile salts, cholesterol, and toxins. These need to be excreted from the body. Okay. Actually, let's correct this. So it's water, phospholipids, and the bile salts. Those are emulsifiers. They help to break down fat. The cholesterol and the toxins need to be excreted, and so does the extra bile. It also needs to be excreted. Okay? If it's not excreted, then it gets reabsorbed. We don't want to reabsorb toxins. We don't want to reabsorb cholesterol. And this is the important feature to consuming fiber in the diet. When you consume fiber, fiber is like a sponge that absorbs the cholesterol and toxins and allows you to excrete it out. If you're constipated, you reabsorb these things. Okay? That's why having bowel movements every single day is so important. Whenever I do a case history on any of my patients, I'll always ask, are your bowel movements normal? How often do you go to the bathroom? For one or two. Okay, number one. You have normal urination? Yes. What's normal for you? Because maybe for some people normal is 3 times a day. Maybe for some people normal is 15 to 16 times a day. That's not, maybe they're normal, but it's not average. So that needs to be looked into. Are your bowel movements normal? Yes, they are. I had one person tell me that her bowel movements were normal. And then I said, well, how often do you move them? She said, every 4 to 5 days. Now, that's her normal. That's the way it's always been. That's her normal, but it's not average. And that's a problem. And I had another young lady come in with a cholesterol of over 500, and that's on a statin drug. I lowered it in less than 7 days to under 200. And that was simply by having her move her bowels and alter her diet just a little bit. But in weeks' time, her cholesterol dropped in half, more than half. Remember, if you're not moving your bowels or eliminating and you're not reducing and removing cholesterol, you're reabsorbing it. So even with a statin drug, her cholesterol was at over 500. And the biggest question is, are your bowel movements normal? What's your normal? And not just how often. I said to her, when was your last bowel movement? She said, what's today's day? I said, today's Friday. And she started counting on her fingers. It was like 6 or 7 days ago. Not healthy. The other question is, are they floaters or are they sinkers? Right? Now, when we talk about bowel, everyone kind of gets a little giggly. They look the other way. They cross their arms when they don't want to open up, so they shut down. So I try and open up that conversation by saying, okay, now we're going to talk about something that everyone hates talking about, yet we all do it. But the information that I get from it is so very important. So we're going to talk about poop. And I talk about poop all day long in my office. So they giggle and they laugh with that. And it's true. And I'll say, how often do you go? How many times per day? And then we'll ask, are they floaters? Are they sinkers? What is the color when you look? What is the color? So that we know that they look. So when you look, what is the color? Is it brown? Is it black? Is it green? Is it yellow? Like, I give them all these choices because they feel like, am I supposed to say that they're green and yellow and slimy, or right? So, and then I have pictures in the office that I can show them and they can point at if they don't want to talk about it. So, but the information that bowel gives us and stool, it's tremendous. And you just have to get very comfortable in discussing it. Here's the gallbladder. And again, just to review, we have some sort of fatty chyme that enters the duodenum, and it causes the release of cholecystokinin from the enteroendocrine cells of the duodenum. And then the cholecystokinin and the secretin enters the bloodstream. The bile salts and secretin are transported by the bloodstream, and it stimulates the liver to produce bile more rapidly. There's vagal stimulation that causes the gallbladder to contract. Remember, the bile is made by the liver, but it's stored in the gallbladder. The vagal nerve, remember the vagal nerve, vagus nerve, cranial nerve 10 in the medulla, C1, C2. Subluxation of atlas or axis can affect digestion tremendously. So making sure that there's no subluxation or interference at that top, at the C1, C2 articulation, can help with so many different digestive disorders. Number 5, the cholecystokinin via the bloodstream causes the gallbladder to contract and the hepatopancreatic sphincter to relax so that bile can enter the duodenum. Okay? These are gallstones. I promised you I was going to show you a picture of gallstones. Now, could you imagine that trying to fit through a cystic duct? Can you understand why it's so uncomfortable? Why people get sick? Why they buckle over? Why they want to throw up? Right? Okay, so for this, for the cholelithiasis, surgical intervention, they could do laparoscopic surgery, or lithotripsy. That's when they break down these stones by using this high energy sound wave. This is what gallstones look like on an x-ray. Here's what they look like on an x-ray where you can see, here's the, this is an A to P pelvis, anterior to posterior. Here's the iliac crest, L5, 4, 3, 2, 1. You can see a few of the ribs here. This is the transverse colon, and they're in pain. So what we're seeing here, this is gas or air. You can see the haustra of the intestines. So they're in pain. So they're gasping for a lot of air. But here are the stones, and it's trying to pass through the ductwork. Then jaundice kicks in, right? Jaundice is yellowing of the skin and the other tissues that result from high levels of bilirubin in the blood. They call it hyperbilirubinemia. Now, it's not a disease. It's not considered a disease, but it is a sign that there's something else going on. If you're of darker complexion, you can look at the sclera. It's often the first place you can notice jaundice. So here on the left, this is good skin, healthy skin. Here is jaundice. Here's the jaundice of the eyes. Definitely go right to liver. Something's up with the liver. So now there's different types of jaundice. There's prehepatic jaundice, intrahepatic jaundice, and post-hepatic, right? Pre means before, intra is within, and post means after the liver. Okay. So prehepatic jaundice is the result of excessive destruction of red blood cells. It's characteristic of hemolytic anemia or transfusion reactions. The liver is normal. It's functioning the way it's supposed to. It just can't handle the excess of red blood cells of the hemolysis, breaking it down into bilirubin. We commonly see this in newborns, right? The jaundice of newborns, and they put them under that blue light to help break down the bilirubin. That's prehepatic, seen in hemolytic anemia or in newborns. Intrahepatic, this is seen with like an infection or a virus. Here we're looking at hepatitis or cirrhosis of the liver. This occurs with disease or a damaged liver or liver cells, the hepatocytes. And it results in decreased conjugation of bilirubin in the liver. What do we mean by this conjugation of bilirubin? I showed it to you in the other slide when we talked about liver detox. It's the conjugation is the process of making bilirubin water soluble. It helps to eliminate in the bile much easier. Now, post-hepatic jaundice, this is caused by an obstruction of the bile flow in the gallbladder or the duodenum. A tumor could do this, a gallstone could do this, or inflammation of the liver. So here's a good visual that just shows prehepatic. This would be like intrahepatic, and then down here would be posthepatic. So when you're looking at prehepatic, that's like hemolysis. This is when the hemoglobin is broken down into bilirubin, and the bilirubin needs to be conjugated in the liver. When the liver can't do that because of, let's say, damage to it from alcohol, drugs, a hepatitis, cirrhosis, then we can't get rid of it. The bilirubin is going to back up into the blood. Okay. When it's posthepatic, that's after the liver. That's got to be some sort of blockage here. This is going to happen in, let's say, a gallstone. This can happen with carcinoma. This can happen in a biliary stricture. So let's look at this one. Here's the normal process, right? Hemolysis, we're trying to take healthy red blood cells at 120 days. Let's break them down. So you have RBC, you got hemoglobin that will break down into globin. These are globular proteins. Some of these can be recycled. And then it's broken down into heme and then iron. So the heme has many different components to it. It's unconjugated bilirubin in the blood. So that unconjugated bilirubin in the blood has to get into the liver. The liver's job is to conjugate the bilirubin, and then it can put that in the bile. The bile gets excreted into the intestines, and then the intestines can eliminate it through the feces or bowel movement. If you have hemolytic anemia, where the red blood cells are breaking down excessively, remember, the liver is normal, but the normal liver can't process the excessive amount of bilirubin, so it spills over into the blood. Okay? With hepatitis, in the intrahepatic jaundice, now we have normal amount of hemolysis coming in, but the liver itself, remember, is starting to become damaged. So there's hepatocellular damage that prevents the conjugation and excretion of the bilirubin. So you're going to get increased amount of conjugated bilirubin in the blood, and the inflammation obstructs the flow in the hepatic duct, so the color of the feces may be variable. It's important that bile is broken down, and when bile is broken down, you get things like urobilinogen and bilirubin and stercobilin. And stercobilin helps to give the feces its brownish color, and the urobilinogen helps to give urine its yellow color. And then there's like biliverdin. There's a lot of other metabolites from the breakdown of the conjugated bilirubin. So asking about the color of the stool is really important, because if it's gray or light colored, we're thinking perhaps there's an obstruction or a blockage post-hepatically, like a gallstone. So the red blood cell breakdown here, the hemolysis is normal. It goes into there's unconjugated bilirubin is normal. It's going into the liver, which is normal. Now it's increased conjugated bilirubin. We're trying to break it down and eliminate it through the bile into the intestines and then remove it, but there's some obstruction in the biliary system. So the obstructed flow to the intestines causes a backup to the liver and the blood. So now you've got the bile increasing in the blood. It can even back up a little bit into the liver. What happens to the bowel? It's much lighter in color. So the type of jaundice is indicated by the increase in serum bilirubin levels and the changes in the stool. So we can't be afraid to ask about the color of the stool. We talked and mentioned about prehepatic jaundice, intrahepatic jaundice, and posthepatic jaundice. In the post-hepatic jaundice with the gallstone, there's increased conjugated bilirubin. There's light-colored stool caused by the absence of bile. And there's increased bile in the blood and the tissues, and that can cause, as I mentioned earlier, itchy skin or pruritus. Okay. Let's look at some liver disorders like hepatitis. We know there's hepatitis A, B, C, so let's take a look at the inflammation of the liver. There's idiopathic, which could be a fatty liver disease. Viral hepatitis, that's a local infection. And there could be infection elsewhere in the body, like an infectious mononucleosis. The liver can become inflamed from other chemical stressors, from alcohol, from drug toxicity, and the inflammation can range from mild to severe with necrosis. Let's look at hepatitis A. It's a small RNA virus. This one is transmitted from fecal to oral route in areas of inadequate sanitation or hygiene. It's also from runoff water, like contaminated water, so it can affect shellfish as well. Sexual transmission has occurred during anal intercourse. The good news is that it is acute but self-limiting infection. There is vaccines that are available for travelers, for food care workers, and for healthcare workers. Hepatitis B, over 50% of the HIV patients are positive for hepatitis B. 50% of the patients are asymptomatic, but contagious because of them being in a carrier state. The hepatitis B can lead to chronic inflammation, and it can also lead to cancer. The transmission primarily infected by the blood, and transmission has been noted through the blood. Tattooing and body piercing may be a way of transmitting this virus. This used to be a common way, even just sharing needles with drug users. But I have known many people that have gotten hepatitis B from tattooing, and not necessarily from using the same needles, but they would dip the needle in ink and then start to ink and then go back into the ink again and then start to inject and then back into the ink. And that ink was being used in different clients, and that's how it was spread. There is also vaccine available here for healthcare workers, emergency care workers, and routinely given to kids. Hepatitis C. This is the most common type of hepatitis transmitted by blood transfusion, and this is the one that has increased risk of hepatocellular carcinoma. Actually, type B and C have been linked to liver cancers. Hepatitis B and C have been linked to liver cancers. There's 3 different stages of the viral hepatitis. They manifest, the manifestations range from being asymptomatic to severe, and in some cases fatal. So the 3 stages are the pre-icteric stage, the icteric stage, and the post-icteric stage. So the pre-icteric stage, there's fatigue, malaise, anorexia, general muscle aching, and the serum liver enzymes may be elevated, typically ALT. ALT is the main liver enzyme. Let's go back to pre-icteric. Let's do the icteric stage. This is where there is the onset of jaundice. The stools now appear to be lighter in color. The urine becomes darker. There's skin itchiness or pruritus. The liver is tender. There's hepatomegaly or megaly, it's enlarged. There's mild aching. And there, in severe cases, the synthesis of blood clotting factors are impaired, so they can hemorrhage. There could be bleeding that takes place. This is a major problem with hepatitis. Remember, one of the functions of the liver is making those clotting factors, vitamin K, prothrombin. The liver is very important for those. And then the post-icteric stage is the recovery stage, where we're hoping to see the reduction in signs, there is usually weakness that can persist for weeks. So here is an exposure to hepatitis B, and the incubation period is about 6 to 8 weeks. So there can be an acute infection that lasts about 4 to 12 weeks, or they could be just a carrier and be asymptomatic. So if they have an acute infection, they could be in the pre-icteric stage. There's malaise, they could be fever, some joint pain. Then it goes to the icteric stage. Now we see jaundice, and many recover. Or they go on to a chronic infection. The chronic infection is a long-term infection, or it leads to cirrhosis, liver failure, or it leads to hepatic cancer. We said that hepatitis B and hepatitis C could lead to hepatic cancer. So the treatment, the only body defense is the formation of antibodies. So it's the exposure to it and producing antibodies, or getting vaccinated and then having the body produce antibodies to that. A lot of supportive measures. We need to give them plenty of rest, a diet high in protein, carbs, the appropriate vitamins to help support the liver. There are many herbs. I know milk thistle is excellent to treat the liver. Chronic hepatitis can be treated with interferon. It decreases viral replication, but it's only effective in a 30 to 40% of individuals, so they'll typically combine, they'll do like drug combination, interferon plus antivirals. They feel that that's a little bit more effective. Now there's non-viral hepatitis, sometimes just toxic or chemicals or overusing of acetaminophen or tetracycline that can cause liver damage. Chemicals like ethanol. Ethanol is found, it's one of the ingredients in gasoline. So it may result from sudden exposure to large amounts or lower doses over a long period of time. When people take medications, it's really important to make sure that you look at the drug and look to see how it affects the liver. Does it affect the cytochrome P450 system? That's really important to know. And aspirin does. Let's look at liver disorders, cirrhosis and liver cancer. Well, you know, a picture's worth 1,000 words. That is cirrhosis of the liver. Altered structure, altered function, basic principle of anatomy and physiology. When you see poor function, we know there's going to be, when you see poor structure, you know there'll be poor function, and vice versa. When the person explains or you can measure poor function, we can assume that there's structural deviation to the organ. So what is cirrhosis? It's progressive destruction of the liver, leading to liver failure. There's alcoholic liver disease. That's probably the most prevalent and leading cause of cirrhosis. There's biliary cirrhosis that can be associated with an obstruction of bile flow or certain immune disorders as well. Now, the problem with cirrhosis is that the liver starts to develop extensive diffuse fibrotic tissue or fibrosis. The lobules become very disorganized. So there's loss of the lobular organism. That's the structural part of the liver. You start to get these nodules. So the hepatocytes can be regenerated, but they may not be functional due to the distorted blood vessels and the biliary ducts, so they become very disorganized. You're losing the loss of the lobular organization, plus fibrosis. You get these nodules. The liver enlarges initially, and then it starts to shrink as the fibrosis progresses. And the symptoms may not appear until it's well advanced. You get continued fibrosis, starts to interfere with the blood supply to the liver. and then bile starts to back up. And then it builds up in the tissues and it builds up in the blood, and you start to get that pruritus and itchiness. So the initial stage of fatty liver, you get the accumulation of fat, you get enlargement of the liver. It's asymptomatic and it's reversible if they reduce the trigger, which is usually alcohol in the alcoholic liver disease. The second stage is alcoholic hepatitis. There's inflammation, and you start to see some necrosis of the cells. There is the beginning of the fibrous tissue formation. But this, because it's still early on, here in stage 1, when it's enlarged, it's reversible. But here in stage 2, because the fibrous tissue is already formed, that's irreversible. When you get to stage 3, now you're at the end stage cirrhosis. You have complete fibrotic tissue that replaced the normal liver lobules and tissue. There's very, very little normal functioning left. So when you have the loss of the liver cells and loss of liver function, there's the decreased ability to remove the conjugation of bilirubin. There's decreased production of bile. There's the impaired digestion and absorption of nutrients. Everything that we did on that first slide with the liver and all of its functions, now it's going to have impact. Decreased production of blood clotting factors, K and prothrombin, which means there's going to be the increased tendency of bleeding. Increased glucose and glycogen metabolism, impaired conversion of ammonia to urea, decreased inactivation of hormones and drugs, so that drugs need to be monitored to avoid toxicity, and decreased removal of toxic substances, right? This is having that healthy fish in healthy water. Those healthy fish, think of them as cells. Think of the water as, the cytoplasm and extracellular substances and interstitial fluid, the waters within the body. Think of it like that. But the cells do create waste products. The fish do poop in the water. But you have a filter. And that filter cleans it out. But after 30 days, that filter gets clogged. And if you don't clean it out, the water gets foggy, it gets dirty, the pH changes, you get ammonia buildup from the fish waste, and then the fish can die from swimming in their own filth. Same thing happens to humans. If the liver isn't healthy, if you abuse it, if you have all those pesticides coming in and all those artificial food colorings going in and putting on all those body creams and colognes and everything you put on your skin that leaches into circulation, everything must go to the liver and get filtered out. If it doesn't recognize it as a protein, a carbohydrate, or a fat, it's a toxin and a poison to the body. Okay, keep that in mind. So what are some of the effects of the disruption? What are some of the effects with cirrhosis? The effects from disruption of bile flow and blood flow. You get a reduction of bile entering the intestines. We showed you that before. It impairs the digestion and absorption. You get backup of bile in the liver. That's going to lead to the obstructive jaundice. You get blockage of blood flow through the liver. Now, this is a new one for us. It leads to portal hypertension. I'm going to show you what this is. Congestion in the spleen can lead to increased hemolysis. Portal hypertension. Let me just see. Here we go. If you look at the liver, here is the portal vein. There are blood vessels that come from the intestines, from the mesenteric vein, and from the splenic vein, and the gastric vein. They all join in to the portal vein. It's like a port. All the ships come into the port. all the deoxygenated blood, all the nutrients from the digestive tract come in to get filtered and cleaned out in the liver. Okay? So after it gets filtered and cleaned out, it goes into the hepatic vein. That's different than the hepatic portal vein. It enters the hepatic vein into the inferior vena cava and then back into the right atrium. So if there's a backup right here, if there's cirrhosis, let's go there. If there's cirrhosis and there's blockage of blood flow through the liver, it leads to portal hypertension. You get a backup here. This is all non-functioning. You're going to get fluid that can't get in, so it starts to backflow out this way. There's a lot of pressure in that portal vein. It's going to go back into the superior mesenteric. It's going to go back into the stomach. It's going to go into the spleen. It's going to go back into the intestines. And you're going to get a lot of edema. That swelling and that edema is called ascites. Right? When there's liver damage, you get portal hypertension. You get this increased hydrostatic pressure in the portal circulation. And fluid shifts out of the portal circulation into the peritoneal cavity. When that happens, you get this large belly that puts pressure on the diaphragm. You get the increased risk of peritonitis. It's going to impair digestion. It looks like this. You see, look at all the superficial veins. This is huge, right? It looks like a pregnancy, but it's not. This is fluid. This is distension. This is ascites. Okay, let's go back. The effects from the disruption of the bile flow and the blood flow, you get inadequate storage of iron and vitamin B12. You get congestion in the intestinal walls and the stomach. You get impaired digestion and absorption. You could develop the esophageal varices, right? From that increased pressure, again, in the esophagus, you can get these varices. And those can hemorrhage. And then you're not clotting very well because you have the loss of those clotting factors, right? Vitamin K and prothrombin. You develop ascites and accumulation of fluid in the peritoneal cavity, and that causes the abdominal distension and pressure. Okay? So then you can get this accumulation again going into the stomach, this puffiness of the stomach, the swelling in the intestines. You can get these esophageal varices. What else? Yeah, that's pretty much it. When you get liver damage, the decreased synthesis of albumin, so there's decreased plasma osmotic pressure, that too will create a fluid shift out of the portal circulation into the peritoneal cavity, causing ascites. And then the decreased blood volume plus the reduced inactivation of aldosterone and ADH, right? It says inactivation of aldosterone and antidiuretic hormone means you have increased aldosterone, which increases sodium reabsorption, and antidiuretic hormone, and now you got water retention. Now you got more edema, more swelling, more fluid accumulation. Initially, the manifestations of cirrhosis are mild. They could be vague. It leads to fatigue, anorexia, weight loss, anemia, diarrhea, dull aching pain in that right upper quadrant. The right upper quadrant is where the liver is. When you get advanced cirrhosis, you get the ascites. You get the peripheral edema. You get increased bruising because of the lack of the clotting factors, the K and prothrombin. You get the esophageal varices. Very, very dangerous. Those can rupture. They lead to hemorrhage, and they can lead to circulatory shock. And then you can get jaundice. You can get that itchiness as well, that pruritus. So here, let's say the skin can get affected. You get that pruritus. You can get the spider nevi. They look like spider veins. You can get the esophageal varices. That becomes a problem. You get the ascites. You get the distended abdominal veins that I showed you. You get rectal varices, not just esophageal varices, but you can get rectal varices. You can get the spleen can become enlarged. You can get pulmonary edema, yellowing, jaundice. You can even get swelling around the brain, encephalopathy, confusion. And in males, gynecomastasia. This is the males develop swelling around here in breast tissue. Females can lose their menstrual cycle. You get increased bruising due to the decreased clotting factors and lots of swelling, peripheral edema. It's got systemic effects, really does. Look with the liver, it's all fibrotic, it's enlarged. So the treatment here for cirrhosis, avoid alcohol, supportive or symptomatic treatment. There may be some dietary restrictions. Balancing the electrolytes are important. Paracentesis, that's draining of the fluid. Antibiotics to reduce the intestinal flora. And emergency treatment if those esophageal varices rupture. And extreme situations, liver transplantation. From my experience and speaking with a lot of emergency room nurses and PAs and physicians, these liver transplants are really designed for trauma and people that have accidents. Those patients make a priority over the self-inflicted ones, meaning if someone is abusing drugs or abusing alcohol, it's not that they won't get one, it's just in terms of priority, they take the accidents over the ones that are self-inflicted. Okay, liver cancer, the secondary or metastatic cancer, much more common for the liver to have metastatic cancer from other tissues. So they arise from areas served by the hepatic vein or spread along the peritoneal membrane. Okay, this should really arise from areas served by the hepatic portal vein, because now that can spread from the spleen, that can spread from the stomach, it can spread from the small intestine, large intestine. Primary liver cancer is relatively rare. The hepatocellular carcinoma, that's the most common primary tumor of the liver, and it's caused primarily by hepatitis B and hepatitis C. The clinical manifestations of liver cancer, initially the signs are mild, they're general. They're similar to other liver disease. You get anorexia, vomiting, fatigue, weight loss, enlarged liver, and portal hypertension. Again, the hepatic portal vein. The diagnosis, minimal early symptoms, and that's because the diagnosis usually takes place at the more advanced stages. And the treatment is chemo, lobectomy, removing the affected lobes of the liver, and then radiofrequency ablation. That is hepatocellular carcinoma, right? This is healthy liver. This is all nodular, fibrotic. This is diseased. Let's look at acute pancreatitis and pancreatic cancer. So the pathophysiology of the acute pancreatitis is inflammation of the pancreas. What's causing the tissues to be inflamed? And I want you to remember that the pancreas is endocrine and exocrine. In terms of endocrine, we're talking about insulin and we're talking about glucagon. The beta cells release insulin and the alpha cells produce glucagon. Insulin designed to lower blood sugar, glucagon is designed to raise blood sugar, and it goes to the liver to release the stored glycogen. But the other portion is exocrine. The majority of the cells and tissue of the pancreas is the acinar cells. So what ends up happening is the inflammation of the pancreas results in autodigestion of the tissue, because of the acinar cells. The majority of the pancreas is exocrine function, and the premature activation of the pancreatic enzymes within the pancreas lead to autodigestion of it. It may be acute, could be chronic. The acute form is considered a medical emergency. This can become very painful. The pancreas lacks a fibrous capsule, and as a result, the destruction can progress. Since it's not capsulated, it can spread to the surrounding pancreas and surrounding tissues. Chemical peritonitis, substances released by the necrotic tissue, leads to widespread inflammation. There's bacterial peritonitis, and septicemia may result from the escape of the intestinal bacteria, the microbiome, and it can lead to adult respiratory distress syndrome and acute renal failure are the possible severe complications. So you have this acute pancreatitis. There are some precipitating factors like alcohol, biliary tract obstruction, cancer, the mumps, and the activation of the pancreatic enzymes inside the pancreatic ducts. So what are some of those pancreatic enzymes? You have lipase that breaks down lipids. You have amylase that breaks down starch. You have trypsin, peptidase, elastase, and you get this autodigestion of the pancreatic tissue from its own enzymes. Then you get tissue necrosis and severe inflammation of the pancreas. The active enzymes leak into the peritoneal cavity and continue to destroy tissue with massive inflammation. That can lead to severe pain, hemorrhaging, shock, peritonitis. The enzymes and cell contents can leak into the general circulation, and they can cause shock, DIC, disseminated intravascular coagulation, adult respiratory distress syndrome. So the acute pancreatitis, the etiology, gallstones, and alcohol. Right? Gallstones can block the flow of bile and or the pancreatic enzymes into the duodenum. And if that flow is being obstructed, it'll backflow into the pancreas. Alcoholic abuse, it stimulates the increased production of the pancreatic enzymes, so it kind of primes the pump. Sudden onset may follow an intake of a large meal or a large amount of alcohol. Because you eat a large meal, it's priming the pump to produce a large amount of those enzymes. The primary symptom is severe epigastric or abdominal pain that radiates into the back. There could be a low-grade fever and abdominal distension. And you can get these decreased bowel sounds due to the decreased peristalsis, the muscular contractions decrease, and paralytic ileus, which is could be nerve damage from the parasympathetics, creating decreased movement. In terms of diagnostic tests, you could check for serum amylase, you could check for serum lipase, and you could check calcium levels and white blood cells. Amylase, this is the first one to rise, and then it falls after second day or 48 hours. The serum lipase can stay elevated for about a week. Hypocalcemia, the calcium levels drop because it binds to the areas of fat necrosis. And then leukocytosis, you get an increase in white blood cells from the inflammation. The risk factors are smoking. There are so many famous people who have developed pancreatic cancer that smoked and that continued to smoke. I'm forgetting the famous actor. He was in that the movie Dirty Dancing. I'm forgetting his name, but he's probably one of the most famous. I remember when he was diagnosed with pancreatic cancer, they did an interview with him. And the interview they did with him, he was smoking. He was smoking through the entire interview. Okay. And what else? The other risk factor for pancreatic uh, cancer is just pancreatitis, acute pancreatitis, and dietary factors can also increase it. The gentleman's name was Patrick Swayze. I was pausing for a little bit because I knew the name would come to me. So if you look up Patrick Swayze, he played the character Johnny Castle. Um, he was just smoking through the entire interview, and that was it. Um, the type of pancreatic cancer, the biggie, is called adenocarcinoma. It's the most common form, and it arises from the epithelial cells that are in the ducts. Adenocarcinoma. When you look at the pancreas, right, there's the head and then there's the body and the tail. So when the head is involved, there's weight loss and jaundice. That's part of the earlier manifestation of pancreatic cancer. When the body and the tail are involved, the person could be asymptomatic until they're well advanced. And that's why the mortality is close to about 95%. Um, it affects the adjacent organs, the liver, the stomach, the lymph nodes, the abdominal nerves. The pain is a very severe um, pain as the cancer progresses. It's not pain management is really the best thing for them. I had an office manager that used to work for me, and her father had pancreatic cancer. And typically 6 months to a year is the time frame. He chose a natural, holistic route. He did not want to go the medical route, and he lived for 3 years. He was able to see his first grandson being born. So, anyway, there's something to say for um, holistic treatments and I don't want to say alternative treatments, but more of the natural, non-invasive approach. And then there's a lot of benefits that come from playing on both sides of the tracks. Doing a little bit of invasive, emergency, um, crisis care intervention, and doing a lot of holistic health. When they work hand in hand, uh, a lot of great things can be accomplished. All right, let's look at the lower GI disorders. We'll talk a little bit about celiac disease, inflammatory bowel disease, IBD, which covers a little bit of Crohn's and ulcerative colitis. So celiac disease, aka celiac sprue, gluten enteropathy, it's a malabsorption syndrome. Primarily affects children. Can occur in adults in middle age. There appears to be a genetic link here. It's a defect in intestinal enzymes, and it prevents further digestion of gliadin, which is the breakdown product of gluten. The toxic effect of this is on the intestinal villi. You actually get atrophy of the villi. When the villi break down, there's the malabsorption, which creates a malnutrition. The first sign appears when cereals are added to the baby's diet. That's somewhere between month 4 and month 6. And then the manifestations are steatorrhea, muscle wasting, failure to thrive, right? Failure to gain weight, irritability, malaise. Those are very, very common. They are diagnosed by a series of blood tests. The gluten-free diet seems to be of benefit, and when they do eliminate gluten from their diet, the intestinal mucosa returns to normal after just a few weeks without the gluten irritation. So here is the intestine. You can see you have all these grooves in here. These are called the plica circularis. You can see here is one particular villi. When you look at the villi, you can see these columnar epithelium, and you can see that they're ciliated at the end. Deep to one of these villi, you can see you have the lacteals. The lacteals absorb the fat-soluble stuff, and then you have the arterioles. When these break down, you're losing the sponge of absorption for the nutrients. Okay, you can see it here. These are the plica circularis. These are the villi. You can see the different layers, the mucosa, submucosa, muscularis, and serosa. The absorption of the food takes place in the mucosa, but you damage these villi, now you start to affect absorption. So celiac is the atrophy of these. Okay, chronic inflammatory bowel disease. All right, so now we're looking at Crohn's disease, and ulcerative colitis. These are both chronic inflammatory bowel diseases. The causes are somewhat unknown, but genetics appear to be involved. Crohn's disease often will arise in adolescence, and the ulcerative colitis somewhere between the second and third decade of life. There are many similarities between Crohn and ulcerative colitis. Let's look at Crohn's first. It can affect any area of the GI tract, but most commonly it affects the ileum. Okay, remember duodenum, jejunum, and ileum. The inflammation occurs in characteristic distribution. They have these skip lesions. These are affected areas that are separated by normal tissue, so it skips and then it targets another area, and then it skips and then it targets another area. It's progressive inflammation, and fibrosis can lead to adhesions. It can lead to obstructed areas. The damaged walls will impair the processing and absorption of food, and the inflammation stimulates intestinal mobility. Crohn will interfere with digestion and absorption. It leads to hypoproteinemia, decreased protein in the blood, decreased vitamins, malnutrition, and steatorrhea. The other complications, you can get these adhesions between the loops of the intestines, and you can get these fistulas that develop as well. In young children, it will delay growth and sexual maturation due to all the malnourishment. And the anti-inflammatories and glucocorticoids seem to be useful in many people. Here is a normal intestinal lumen, and you can see these granulomas that form in Crohn. These are more extensive, so they would do a recession here. They would cut out this part of the lesion. The most common place for Crohn to attack is going to be the ileum, right here, primarily the ileocecal region. Okay, so here is the ileum, and here is the cecum. So the ileocecal region is the most common. This is where, remember, the absorption of B12 takes place. So if they do have to resect this and remove this, then there's got to be B12 supplementation, most likely sublingual. So you can see here is the colon, looks like the ascending colon. Here's part of the intestines. So the red areas are the ones affected, and these are the skip lesions. So you have this distribution of the affected segments alternating with normal segments of bowel in between. Here we have a rigid, thickened wall. There's some fibrosis here. This is thin. This is more flexible. We have inflammation. You have some ulcers that forming. And then here you've got some fistulas that form. This is an opening between two structures, kind of like you have not just inflammation, but it erodes the wall between this and this. Now, ulcerative colitis, this is still an irritable bowel disease. The inflammation here starts in the rectum, and then it processes through the colon. It can affect the mucosa and the submucosa. They become inflamed. There's tissue destruction that interferes with the absorption of fluid and electrolytes in the colon. There are severe acute episodes. It creates this toxic megacolon, may develop. There's marked diarrhea with up to 12 bowel movements or stools per day. The bowel movements and the diarrhea contain blood, they contain mucus, and very, very cramped. This is manageable. I have several patients that I treat that have this. This is a great comparison between Crohn and ulcerative colitis. If you look at the region affected with Crohn, you're looking at the ileum with the ulcerative colitis, rectum and colon. In terms of distribution of the lesions, you have these skip lesions. With the ulcerative, it's the mucosa only. With the stool, here it's loose with Crohn, semi-formed, but with ulcerative, it's frequently watery with blood and mucus. The granulomas will show with Crohn, the fistulas show with Crohn, and the strictures and obstructions show up with Crohn. But rarely do they show up with ulcerative colitis. There is malabsorption and malnutrition with Crohn, but not very common with ulcerative colitis. The treatment is remove the source of the stress, whether it's emotional or physical or chemical, just remove it. Anti-inflammatory medications, anti-motility agents, nutritional supplementation, antimicrobials, immunotherapy, and surgical resection. All right, last round here, and then we'll be finished. We'll look at irritable bowel syndrome, appendicitis, diverticular disease, and colorectal cancer. So just to review, here's the ascending colon, transverse colon, descending colon, sigmoid. Here's the rectum, and then the anus. Then you have the flexures. You got the right hepatic flexure, also known as the hepatic flexure, because the liver is here. And then you have the splenic flexure, or the left colic flexure. These are called haustra. I think we saw these on the film, the X-ray, where you saw the shape, and it was filled with air because the patient had a lot of air and gas in here from the pain. Okay, here is the ileum leading into the cecum. So this is the ileocecal valve. And then you can see the blood vessels that lead here. They're coming off the abdominal aorta. So there is the inferior and superior mesenterics. So IBS, there's abnormal gastrointestinal mobility and secretion. There's diarrhea with rapid transit time. There's constipation with slow transit time. So it goes between diarrhea and constipation, and that's what IBS typically shows up as. And it's believed to be a hypersensitivity to serotonin that's on the enteric nervous system. When you have too much serotonin, like if someone's anxious or they're having an anxiety attack, then they run to the bathroom. If someone has too little serotonin, like they're depressed, then they're constipated. Okay, so too much serotonin, you have diarrhea. Too little serotonin, you got constipation. There's also visceral hypersensitivity. Increased sensitivity to the visceral pain can be due to the hypersensitivity to serotonin, as well as activated by mast cells and the T lymphocytes. Remember, the mast cells are located in the GI tract. They're found in the skin and the respiratory tract, and they release histamine. And histamine can result in the dilation of the smooth muscle, and you can get diarrhea as well from that. With IBS, there's post-infectious IBS. There's overgrowth, or the microbiome could be out of balance. There could be food allergy or food intolerance IBS, and also psychosocial factors. The clinical manifestations, they have pain in the lower abdomen, there's diarrhea, there's constipation, or alternating between diarrhea and constipation. They feel bloated, they feel nauseous. The diagnosis is really based on the signs and the symptoms. They can be tested for food intolerance or food allergy. They can also be tested for any type of bacteria or parasitic infections. There's really no cure for IBS. It's more of like management of it. Let's look at appendicitis. This is an obstruction of the appendiceal lumen. It could be obstructed by a fecalith, gallstone, or any type of foreign matter. You get the fluid buildup inside the appendix. You get the appendiceal wall can become inflamed with this purulent exudate, and the appendix becomes very swollen. It can become ischemic and necrotic, and it can result in increased permeability. Here's the cecum, and here is the vermiform appendix. Here it's inflamed. That's what an inflamed appendix looks like. And the location of it, if you find the umbilicus or the belly button, and then you go on a diagonal to the anterior superior iliac spine, and you go at about the midway point. That's called McBurney's point. Now you could do rebound tenderness, where if you push straight down with the fingertips on the belly, usually you'll feel severe muscle guarding to protect it. And when you push in, it may be sensitive, but it's more painful when you quickly remove and you rebound your hand quickly away from that region. It becomes very, very painful and sensitive. Okay, that's called McBurney's point. It's halfway between the umbilicus and the anterior superior iliac spine. There could be bacteria and toxins that escape in the surrounding tissue. It leads to an abscess formation. The abscess may develop when the inflamed area is walled off. The inflammation, the pain could be temporary. It can also subside, or it can spread. It can spread along the peritoneal membrane. That's if you have this localized infection, or the peritonitis develops around the appendix. Now, if it explodes, and now it could spread throughout the entire abdominal area and throughout the entire peritoneum for sure. The increased necrosis and gangrene in the wall, it's caused by the increased pressure in the appendix. The appendix can rupture or perforate, releasing all of its contents into that peritoneal cavity, and this could be life-threatening. So IV or antibiotics if that happens. Generally, there's pain around the entire umbilical region, so they call it periumbilical pain. That's related to the inflammation. There's nausea and vomiting. The pain becomes very severe in that right lower quadrant where McBurney's point is, and you can get that rebound tenderness that develops. So here's the muscle guarding that's felt. Then you push your hand, like the fingertips, straight in, and then you quickly recoil. You pull it away super fast, and that creates a lot of pain. That's a positive indication of appendicitis. Okay, so after the rupture, the pain subsides temporarily. The pain can reoccur. It could be severe. It could be generalized abdominal pain, and there still could be that muscle guarding. There could be low-grade fever with increased white blood cells, or the abdomen could be very, very tight and stiff. There could be tachycardia. There could be hypotension. As the peritonitis develops, the abdominal wall spasming takes place around the entire rectus abdominis. The toxins can lead to reduced blood pressure as well. The treatment, surgical removal of the appendix. I'm going to say about 10 or 15 years ago, I had a patient that came in to me, and he had some lower back pain, and I was doing a case history on him, and he had told me that, he went to the doctor, to his primary physician, about 3 weeks prior. And I said, how did it go? He goes, the craziest thing happened. I said, what happened? He said, on general checkup, they saw that I had high white blood cell count. And all of my other tests kind of came back normal. And I told him I had a lot fever for about a day. I had a little bit of a bellyache. They did an ultrasound on him, and they saw that his appendix wasn't there. So they had made the determination that his appendix ruptured, but a few weeks prior. So he felt fine. He had no adverse reactions. He went to work. Nope, he had a fever, a high fever for a day, and that was it. They ended up giving him antibiotics anyway, but as a prophylactic precautionist measure. But it looks like his body handled it itself. He spiked the fever, burned it off, and his body went back to normal. So this was the only case that I ever heard of because I've always heard of appendicitis, and you want to get to the hospital before it explodes. If it explodes, it can lead to septicemia, and it could kill you. This guy had the thing explode, didn't even know he had a fever for a day, went on for his life. Almost a month went by, and the only way he knew was just from a general blood test, saw higher white blood cell count, and then they did the ultrasound and caught it. So here is the generalized umbilical pain. Then it leads to more localized right lower quadrant pain in that McBurney point, right halfway between the belly button and the ASIS. If a rupture happens, the pain can decrease temporarily, but the rupture can spill all of the toxins into the peritoneal cavity, and that causes severe muscle guarding in here. All right, diverticular disease. Diverticulum are these outpouchings or herniations of the mucosa through the muscular layer of the colon. Diverticulosis is asymptomatic diverticular disease, and diverticulitis is when they become inflamed. Let me see if I can show you. Well, they do get cramping and tenderness and nausea, vomiting, and the back pain. I had a gentleman that came to see me not too long ago that was having back pain. His belly looked a little swollen. We palpated the belly. He had a little muscle guarding. We sent him to a primary, to a gastroenterologist, and they found that he had diverticulitis. And they gave him antibiotics, and after a few days, he was back to normal. Slight fever, elevated white blood cell count. That happens when you have diverticulitis, right? The stases of material in the diverticuli can lead to inflammation and an infection, especially if bowel gets caught inside those little out pockets. The treatment is going to be antimicrobials and dietary modification, which is probably increase the fiber, increase the water, and try to decrease the fatty foods for a little while. So you have the ascending colon, transverse, descending colon. Here's a bleeding diverticuli. Here's diverticulitis. This one is infected or inflamed. And these are the asymptomatic ones, diverticulosis. Here you can see you got the out pockets. Now if bowel gets caught in here and one of these blood vessels rupture, now you can get spread of these bacteria into the blood, and you can get bacteremia or septicemia. The colorectal cancer, most malignancies develop from adenomatous polyps or edematous polyps. Again, most malignancies or colorectal cancer develop from adeno or having a brain lapse here. Adenomatous. I'm going to skip that one for now. It's late, folks. Polyps. Okay, so when they do a colonoscopy and they find polyps, they will typically remove them. They'll send them to a pathologist or a histologist, and then you wait for a call. And they'll let you know whether it's benign. Majority of them are benign, but some are malignant. So early detection, early diagnosis is really essential. Going for these colonoscopies are really important. Starting in the 50s, I started mine in the mid 40s, just as a preventative and being super, super cautious. The risk factors are family history that has these polyps, long-term ulcerative colitis, genetic factors, environmental factors, and a diet that is low in fiber. You could decrease your chance of getting colon cancer by making sure you have about 40 grams of fiber in your diet every single day. Some of the initial signs, it really depends on the location of it. But the general signs are going to be change in bowel habits, again, alternating between diarrhea and constipation. There's bleeding, fatigue, weight loss, and anemia. Right there it is again, fatigue, weight loss, and anemia. The treatment is removal along with radiation or chemotherapy. One of the other signs when you talk about change in stool habits, pencil thin stool. Uh, as bowel is trying to fit through, like here's the normal size of the lumen, all of this is the cancer. So what's left of the lumen is this little space here. So that's why when we ask about when you look, not only what is the color, what is the shape, what is the length, all of this information really does matter. So pencil-like thin stool is a strong indicator of colon cancer. Again, losing, 15 pounds in 2 weeks or 30 pounds in the month with anemia, fatigue, and anemia, a good indication of colon cancer. So this is where cancers can occur. In the ascending colon, there could be liquid stool, there could be occult blood. Here in the transverse colon, you can see here is a tumor that's pressing on a little bit here that can change the bowel habits. Here in the descending colon, it looks like it's wrapping around, which can compress it, creating an obstruction. So the cancers can take place in different parts of the colon, and that's why asking about bowel movements is so very important. Okay. Intestinal obstruction and peritonitis. Let's see, what do I want you to know about this? So, intestinal obstruction, the lack of movement of the intestinal content through the intestine, more common in the small intestine. There could be mechanical obstructions like tumors, adhesions, hernias, and other tangible obstructions. Um, it could come from impaired peristalsis from lack of nerve supply or spinal cord injury, or paralytic ileus caused by toxins, or electrolyte imbalances that can also affect the neurology. Um, Functional obstructions or the paralytic ileus can come from abdominal surgery, spinal shock, inflammation related to severe ischemia. It can happen from pancreatitis or peritonitis or infection of the abdominal cavity. Hypokalemia, not calcemia, but kalemia. This is potassium. There could be mesenteric thrombosis, some sort of clot to the superior and inferior mesenteric arteries, and toxemia. The mechanical obstruction can happen from adhesions or twisting of the intestines, or hernias, or strictures, or masses, intussusception, or volvulus. I'll show you what these are, as well as Hirschsprung's disease. These tend to be somewhat congenital. So here is a herniation right through the abdominal wall. Here is adhesions between two parts of the intestine. Here's intussusception. It's almost like a telescoping effect where part of the intestine folds into another part. And then you can have a volvulus, which is like a twisting of the intestines. Here's Hirschsprung's disease. This happens primarily down here in the sigmoid colon, where there is a twisting or obstruction of the sigmoid. Okay, this is a normal sigmoid colon rectum, and here is the swollen colon from Hirschsprung. So the clinical manifestations, the mechanical obstruction of the small intestine can cause severe colic, abdominal pain. There'll be intermittent bowel sounds. Remember the Borgamus, the intermittent bowel sounds. There'll be paralytic ileus, where the bowel sounds decrease or they're absent because there's no peristaltic movement. It's just paralytic. Vomiting and abdominal distension. This occurs quickly with the obstruction of the small intestine, and vomiting is recurrent. The obstruction of the small intestine, this is considered a medical emergency. The clinical manifestations, if you have an obstruction of the large intestine, these develop slowly with mild symptoms. They'll often see constipation. There'll be mild abdominal pain followed by the distension, and then anorexia, vomiting, and more severe pain. And the treatment is really treating the underlying cause, monitoring the fluid intake and the electrolyte balance to replace them, surgery, and antimicrobials if needed. With peritonitis, this is inflammation of the peritoneal cavity. This can result from pancreatitis. Remember the enzymes released with pancreatitis? Or any urine that leaks from a ruptured urinary bladder, or if chyme is spilled from any perforated ulcer, or if bile escapes from a ruptured gallbladder, if blood escapes, or any other foreign material in the cavity, it can spread within that peritoneal cavity. All of those organs are found in the same cavity, so if it leaks, then it can spread, and it can, think of it as spreading or metastasizing to other parts. Metastasizing may not be the right word because that usually refers to cancer, but spreading through that same membrane. With bacterial peritonitis, it's caused by direct trauma affecting the intestine, or let's say the appendix ruptures. Any abdominal surgery, sometimes they accidentally leave some foreign material in there. Also, with PID, pelvic inflammatory disease in women, when we get to male and female reproductive tracts, we'll talk about pelvic inflammatory disease when we cover the women's. When an infection reaches the cavity through the fallopian tubes. The pain can be sudden, severe, and generalized abdominal pain. It could be localized tenderness at the site of the underlying problem. Vomiting is common. Again, the abdominal distension with peritonitis, low blood pressure, tachycardia, right, the fast heart rate, fever, increased white blood cells, and the treatment really depends on the primary cause. Surgery may be required. Antimicrobial drugs may be required as well, but it has to be specific to the causative organism.